Hi guys, so welcome to my channel, Dr. Z, the AIIMSified WombWhisper. Today I'll be teaching you obstetric examination. In my last video I have talked about obstetric history taking. So that was the basic format of any obs case you'll be going to see in your ward or OPD, or like when you are preparing for your exam. So you can take history in that case, which I have talked earlier, and now I am going to teach you about the op examination format. These are perfect for the junior residents. Actually these are in little detailed way. Even MBBS student can present in this way, but I am also talking about little details about the points we are taking in history or examination. So JRs should know this, at least DNB students and JRs, and MBBS students should also know, because when you are explaining your history correctly, so you may be asked about the details of each point. So let's go forward to learn the obstetric examination. So there are some prerequisites. Okay, so when you are going to examine a patient, there are some prerequisites which you should be following. First is verbal consent, and then explaining the patient what you are going to do. So whenever you are going to examine a patient, you should explain her, okay, you are going to do her physical examination, or you are also going to perform per abdomen or local examination. You should always explain, and only after patient allows you to do so, then only you can proceed with your examination. Okay, and then in case if you are a male doctor, you should always have a female attendant or your female colleague along with you doing the examination. And privacy is very important during examination. Like, you should not examine her in front of other patients or other patient parties, or like when doors open. You should always examine her in a private examination room, or at least with the screen for privacy. And then you should tell the patient to empty her bladder, because if you examine her with full bladder, it will be very uncomfortable for the patient. And the room should be well lit wherever you are examined, so as to perform your inspection or palpation correctly. Now, so in these two slides I'll be talking about the format in which you should be taking the obstetric examination things, and it should be like in this format only, like general physical examination along with head to toe examination, and then followed by systemic examination and summary and provisional diagnosis. Okay, so I'll first tell you about the points, which point you should be taking, and then we can talk in details about why this point and what questions can be arise from this point while you are presenting a case. So this is the basic format of obstetric examination. Whatever case you will be getting in ward or OPD. In OPD we don't do this much exhaustive workup for a patient, but when a patient gets admitted to ward, or you are preparing for any exam like obs exam, so for case presentation or like practical exam purpose, you should be presenting in this way only. So first is general physical examination. So you should start writing like this: your patient is alert, conscious and cooperative, oriented to time, place and person. Then she is sitting comfortably at rest. Her general condition appears fair. She is average build with good nutrition. Hydration is adequate. Then you should take the vitals: pulse, BB temperature, respiratory rate and saturation, and then anthropometry, height, weight and BMI. Then you proceed to head to toe examination, which includes like pyloric-trus cyanosis, like the short form is PICL. We take pyloric-trus cyanosis, clubbing lymphadenopathy, and then edema. Then you go to hair, skin, nails, if it is normal or not, spine, skull gate, if any abnormality is noted, and orodental hygiene. Then you look for the neck veins, if it is dilated or there is any abnormality, and if the thyroid glands appear enlarged or not. And breast examination is very much important in obs patients, so you do breast examination also. And then you proceed to systemic examination, which includes CNS examination, then CVS, then respiratory system, and then per abdomen. This is the most important part of any obs examination. So when any examination is in hurry, or he is in no mood to take your full to listen to your full history and examination part, then he will straight away go to the abdomen part, per abdomen, how you have written or how you are presenting the case to him. So this is the most important part. And then pelvic examination in some selected cases, not in all cases. So those patient in whom you want to do pelvic assessment at term, so we want to see her if she will be able to undergo normal vaginal delivery. So for pelvic assessment at term, when patient is in labor or preterm labor, or she presents with leaking PV, prom or PPROM. And then after the examination part, you write the summary and provisional diagnosis. So this completes your obstetric examination along with summary and provisional diagnosis. So you should be writing in this format. Okay, in many places formats are here and there, like sometimes it is some things are given and some are not. So nothing is wrong, but this is a wholesome format, so you can follow this. Now come to detailed part, why we are taking each point and why it is important. So firstly, you should always mention how your patient is, like if she is alert, conscious and cooperative while giving history or while you are doing the examination, if patient is oriented to time, place and person, because if something is wrong in this part, then there is some gross wrong thing with the patient. So this should be always there. It is like basic thing you present in medicine or surgery ward or exams. So if your patient is sitting comfortably at rest, because there may be many patients in OBS cases, like heart disease patient in OBS case, NYH 3-4, she may not be comfortable at rest. She may be, breathlessness, she may be having breathlessness or respiratory difficulty while sitting or while lying down. So you should always mention this point also. And if her general condition appears fair or not, while patient is sitting or she is talking to you, how is her general condition? If she is sick, if she appears sick while talking to you, how is her build? If she is thin built or average built or obese, because build is important. In case of obese patient, obesity may have many complications. Similarly, thin patient, she may have complication of nutrition, anemia, and then subsequently HGR, etc. So while you present the case, now examiner may ask you how will you assess nutritional status of the patient. So you should answer firstly by skin fold thickness, then by mid-arm circumference, and there may be features of vitamin deficiency through which you can assess nutritional status. Skin fold thickness, you may remember that in school time you used to be taught that skin fold thickness can be measured by vernal caliper or something like that, and it is up to 5 to 10 mm in male patient, and in female it is up to 15 mm. Okay, in women, skin fold thickness. Mid upper arm circumference, we take it with Sakir's tape. So anything less than 23 is decreased mid upper arm circumference, which may indicate malnutrition, and anything more than 32 is indicates obesity. Okay, and features of vitamin deficiency we can see like chillosis or stomatitis, glossitis, brittle hair, nails, etc. And nutrition, and then hydration, whether it is adequate or not. So how will you assess the hydration of the patient? You can do it by looking at the tongue or the lips of the patient if it appears dry and chapped, or you can also do skin pinch test to assess hydration. Now vitals. So in vitals, you know how to take pulse. You take it in the radial artery, you assess the rate, volume, rhythm, condition of the vessel wall, if any differences between the both the radial artery of both the forearms. So if there is any radial or radiofemoral delay. BP. So here is where the question arises. What are the prerequisites for measuring the BP? How will you measure the BP? What should be the ideal cuff size and all? So whenever a patient comes to you, should not immediately take the BP, because the patient may be coming by walking or just running when in hurry. So you should always tell the patient to rest for few minutes, at least 5 to 10 minutes, before taking the BP, and while taking the BP the patient should be sitting or she should be in left lateral recumbent position, and she should never be supine. Why? Because it may, in pregnant patient, mostly in second and third trimester, there may be supine hypotension while patient is supine, so you should always be telling the patient not to lie down but to sit or be in left lateral position while taking the BP. And you should support the arm of the patient. She should be relaxed and her hand should not be hanging. You should always give your arm like this, and you should support the arm of the patient in your arm, or if the patient is sitting in an armchair, then there is already an arm support. The arm level, so the cuff should be applied on the right arm at the level of the heart. What should be the appropriate cuff size? So the width of the cuff size should be 2/3 of the arm circumference, and the length should be at least 80%. Length of the cuff should be at least 80% of the arm. And if you find the BP reading is high, you should always repeat the BP, okay, after 10 to 15 minutes. And which Korotkov sound denotes BP in a pregnant patient? So Korotkov 1 indicates systolic BP and Korotkov 4 indicates diastolic BP. In normal patient we take Korotkov 5 as diastolic BP, but in pregnant patient Korotkov 4 is more accurate. And temperature we can measure in axillary temperature, though rectal temperature is more accurate, but it is cumbersome and very uncomfortable for the patient, so we don't do that normally. And respiratory rate, it is same as in non-pregnant patient, that is 12 to 20 breaths per minute, but it is thoraco-abdominal. Okay. In anthropometry, BMI. So BMI is very important. Why? Because BMI tells us many things about the patient and what complication we may anticipate in our pregnancy. And the most important thing is, in BMI we always take the pre-pregnancy weight, not the current weight in the pregnancy. Okay. So first thing is you calculate BMI to decide on the calorie requirement of the patient. So there is basic calorie requirement which increases in pregnancy, and depending on the BMI of the patient we tell her to take her meals. So you cannot tell same amount of to take same amount of meal for a lean and thin patient and to an obese patient. So there is difference on calorie consumption and requirement of the patient. So we should calculate BMI. Height is important because short height patient, likely less than 140 centimeter, likely to have small pelvis which is inadequate for vaginal delivery. So that is why we do pelvic assessment at tongue in any patient before allowing her for vaginal delivery. And weight should be taken at every visit of the patient, at every ANC visit, while a patient is being admitted in the ward or while you are working up a patient. And we should always check the BP and the weight at every ANC visit of the patient. And weight should be checked preferably in the same weighing machine every time, because there may be some inaccuracy like in every machine. And weight gain has to be recorded because there are some recommended kgs of weight gain in pregnancy which should be allowed for a patient, so as to for the betterment of her and the baby. In head to anemia, questions can be like where to look for anemia, as they ask you in medicine and surgery also. So lower palpebral, conjunctiva, dorsum or tip of the tongue, soft palate, nail bed and skin, like palms, skin of the palms. And then where to look for jaundice, where to look for cyanosis, central cyanosis and peripheral cyanosis. Where clubbing, clubbing is, we also check for lymphadenopathy. So we look for cervical and then axillary and then inguinal lymph nodes. Edema. So there are few questions in edema part. So they ask you where will you look for edema, how will you look, and how you define the edema of the patient. Is every edema pathological? So no. The most common cause of edema in pregnancy is physiological. Okay. And physiological edema is due to increased venous pressure on the inferior vena cava by the uterus. So there is stresses of there is what do you say, transudation of fluid, which may lead to edema of the legs also. So where do we commonly look for the edema? We look over the medial malleolus of the leg and anterior surface of the lower 1/3 of the tibia, shin bone. So we can press it for 5 seconds and we look for if there is, dimpling of the skin. And what are the other sites of edema? So we can also look over the sacrum, parietes, like abdominal. In cases of abdominal edema, you can also see like orange appearance, pudy orange appearance over the abdominal wall also in case of edema. So we look over the sacrum, parietes, and over the vulva also we can look for edema. So what are the causes for edema? Most common is physiological, and pathological can be due to preeclampsia, anemia, hypoproteinemia, cardiac disease, and nephrotic syndrome. And then another question is, what are the features of physiological anemia, physiological edema? So physiological edema are always slight, they are not major or is not so worrisome for the patient, and it is mostly more on the right side because of same reason, like disc rotation of the uterus. So there is more compression on the right side, and it is not associated with any other features of preeclampsia or proteinuria. You will always find the BP is fine, albumin is fine, and when you tell the patient to take rest, to elevate her legs while sleeping, the edema disappears in the next morning itself, and other pathologies are absent. And how do you grade edema? So grade 1 is up to or below the ankle, grade 2 edema is above ankle but below knee, grade 3 edema is above knee, and then grade 4 edema is anasarca, that is involving the whole body. And skin, hair, nail, you look for if the skin is dry or brittle, or there is koilonychia or platinichia, like flattening of the nails. You look for the orodental hygiene of the patient because it is important. It will tell us about if there is any evidence of malnutrition or not, cheilosis, glossitis, angular stomatitis, and it will also tell you about if there is any infection in the mouth or not, because if there is, you need to treat it, because it may lead to infection again in the puparium, and already the patients are immunocompromised in her puerperal state, so we need to treat it. You also look for the neck veins in the neck, you look for the thyroid gland. Normally in around 50% of the patient, thyroid gland may be slightly enlarged, but any abnormality you see, like more than normal, if you can palpate any lump or any mass in neck, you should always report it and evaluate it for the patient. And breast examination, it is very important, it is very, very important. Why? Because there are some changes, pregnancy changes in the breast, like Montgomery tubercles, darkening of the nipple areola complex, and there is hypertrophy of the breast also, breast tissues. And we should also look for if there is any cracked or depressed nipple, because if the nipple is depressed, then there will be problem during the puerperal period when mother is trying to feed the baby. So it will be problematic for both the mother and the baby. And if the nipple is inverted, so we need to treat it with they treat it with creating suction using the syringe. Okay, so if we treat it, there will be no difficulty in breastfeeding for the mother. Now comes abdominal examination. So we need to do abdominal examination in details, mostly beyond 28 weeks, because we can now palpate the uterus, we can make out the lie of the baby. So it should be in detail, and it should be done in every antenatal visit of the patient, because lie may change, there may be growth restriction of the baby. So how will you know this? Only by examination. First thing is examination, and then ultrasound and other test. Okay, so there are some preliminaries before examination. Same, verbal consent, as always, it is very important. You ask the patient to empty the bladder. These are the very important and small points, but we always tend to forget it in examination. Even me, like in my MBBS examination or MD examination, everyone forgets it. one point or other. And these are very important, because examiner knows where we tend to forget things, and they pick up at us there only. So we should not forget. Consent is important, bladder emptying is important, female attendant is important. You should be examining the patient by standing on right side of the patient. You should always explain the patient what you are doing, okay. And how the patient should be lying. She should be lying in dorsolaterotomy position, that is, patient should be supine, but knees and legs should be slightly flexed. And from where you will expose the patient, from where to where. Normally in medicine surgery patient, when we are examining the abdomen, we expose from mid chest to mid thigh, but in obs patient we don't need to expose that much. We expose from xiphy sternum to pubic symphysis only. So that much exposure is enough for obstetric examination, per abdomen examination. So first thing is inspection, and then palpation, and then auscultation. There is no percussion in obs exam. So in inspection, what points you should mention? So these are the points you should mention while you are writing per abdomen examination as inspection. So if abdomen is uniformly enlarged or not, if the uterine ovoid, sometimes we see the ovoid is longitudinal or transverse. In transverse slide you see the flanks are much fuller than the fundal height. So whether the uterine ovoid is longitudinal or transverse, or it is oblique, or if sometimes you see there is what we call as fundal notching, means you see there is an abrupt change of shape at the level of xiphy sternum, mostly in term patients. So that is called as fundal notching. So you look for, if the abdomen is uniformly enlarged, then you look for the uterine ovoid. Then you look at the umbilicus, if it is central, inverted or everted. Towards the term time, it can be everted, and it can be flat also. Then you look if all the quadrants are moving well with respiration. You also look for the presence of stria gravidarum, like laterally there may be stretch marks, and then at the center there may be a hyperpigmented area which is called as linea nigra. So you look for the linea nigra and the stria gravidarum. You also look if there is any other scar, like most commonly you can see scar for previous cesarean section, or appendicectomy, or cholecystectomy scar, or any laparoscopic scar. So you look for those scar also, and mention if there is presence of any scar other than these two. And also look if hernial orifice sites are intact. How do you look for it? You tell the patient to turn her face to other side and then cough, and you look at the inguinal region for any cough impulse. So if there is any cough impulse, if there is any bulging or swelling on cough impulse, then there may be some hernia, otherwise you mention it as intact. Now comes palpation, very important. So you stand on the right side of the patient, you make the patient lie supine with thighs and legs flexed, you cover the patient from below and tell her to elevate her clothes till xiphy sternum. Then you sanitize your hand, and you should also rub your hand during winter season. You should not just touch the patient directly. She may feel little jerky or uncomfortable when you touch with your cold hand. So always sanitize and warm your hand before touching the patient. Then first thing is you measure the fundal height. So how will you measure? You should first always correct the dextrotation. So you can put your hand like this while you are standing on the the right side of the patient. You have to measure the fundal height with the ulnar border of the left hand. So with the right hand you correct dextrotation by pushing the flank little towards the center, and with the ulnar border of the left hand you start measuring the fundal height starting from the xiphy sternum, and always be gentle with the patient. So you just start from the xiphy sternum, you come down and down until you feel any resistance, and stop at the first resistance. Don't push it, otherwise fundal height will be wrong. Just stop at the first resistance. So how will you know that wherever you have stopped what is the fundal height at that point? So there are some rules. So if it is just above, you can palpate the just above the pubic symphysis, it is 12 weeks. And from the lower border of the umbilicus and upper border, there are two borders of umbilicus, right, lower and upper. So lower border of umbilicus is 20 weeks, and upper border of umbilicus is 24 weeks. So between lower border of umbilicus and pubic symphysis, we divide it into two halves, and after 12 weeks it comes to 16 weeks, and then 20 weeks, and then 24 weeks. Okay, so 12 weeks is just above pubic symphysis, 16 weeks is midway between pubic symphysis and lower border of umbilicus. Lower border of umbilicus corresponds to 20 weeks, upper border corresponds to 24 weeks, and then from the upper border of umbilicus to xiphi sternum, you divide it into three halves. Okay, so the first half will be 28 weeks. First 1/3 will be 28 weeks, second 1/3 will be 32 weeks, and the upper third will be 36 weeks. Okay, and towards the term, the fundal height will come down, but the flanks will be full. So this is how it is. So there are 3 points: xiphi sternum, then umbilicus, and then pubic symphysis. Up to pubic symphysis 12 weeks, lower border of umbilicus 20 weeks, between this 16 weeks, upper border of umbilicus 24 weeks. Here you divide it into three equal parts. First part will be 28, then 32, then 36, and then at term it will decrease, but the flanks will be full. Okay, so you got it. This is how we note the fundal height. And always be gentle with the obs patient. You should not be, your palpation should not be rough, your palpation should not be tight, it should always be gentle. After measuring fundal height, you mark the point till where you have felt the resistance, you mark the point, then you measure symphyso-fundal height. How will you measure symphyso-fundal height? So you need 1 inch tape, and you with one end of the inch tape should be placed at pubic symphysis, and the other end should be placed at where you have marked the fundal height. So this length is symphyso-fundal length. And what is the significance of this length? This after 24 weeks, this symphyso-fundal length in centimeter corresponds to your period of gestation in weeks. Okay, so if the symphyso-fundal length is suppose 28 centimeter, so it corresponds to 28 weeks POG. Similarly, abdominal girth you take with the help of an inch tape at the level of umbilicus, and it corresponds to period of gestation in inches. And remember, while measuring the abdominal girth, the inch part should be away from you. Means in an inch tape there is 1 centimeter part on one side, and then on the other side there is inch. The measurement are given in inch. So while measuring the abdominal girth, you should always hide the inch part so as to avoid any bias while measuring. Okay. And while you are measuring the fundal height or the symphyso-fundal length, height, there may be some discrepancy. You may find, okay, your symphyso-fundal length is coming to be 28 centimeter, but your fundal height is only 20 centimeter, or your symphyso-fundal length is coming to be 28 centimeter, but your fundal height, but your your period of gestation is 32 weeks. So why the discrepancy? So in cases where uterine height, means fundal height, like is more than the period of amenorrhea, that is period of gestation. Suppose from LMP you calculated 28 weeks, but while measuring fundal height it is coming to be 32 weeks. So what can be the reason? The first and the most common reason is wrong date. So your dating may be incorrect. Second, there may be twin pregnancy. Third, there may be polyhydramnios. Fourth, baby can be big, macrosomia. Then there can be pelvic tumor like fibroid, which is just falsely increasing the height of the uterus. There can be H mole, there can be hyperproliferation of the trophoblastic tissue, and then you'll be getting the fundal height greater than the period of gestation. And there can be concealed antepartum hemorrhage, that is concealed placental abruption. And in cases where the fundal height is less than the period of amenorrhea, suppose the period of amenorrhea is 36 weeks, but your fundal height is only 32 weeks, then again incorrect LMP dating, the first thing to come to your mind. Then oligohydramnios, there may be IUGR and there may be IUFT. Old IUFT patient may not be knowing, sometimes primary may not be knowing. Okay. Next comes Leopold maneuver. This is the heart of obstetric examination, Leopold maneuver. And similarly, there are some key principles of abdominal palpation. Always palpate with light and careful movements. Your hand movements while you are touching the patient or palpating should be always gentle and light. You should not be poking the patient with your hand. It should not be clumsy and random. It should be a systematic palpation. And you should always pause during contraction. Already patient is having pain during contraction. You should not, and the uterus becomes hard, so you won't be able to palpate also, and you'll be giving more pain to the patient also. So it's better to stop during contraction and palpate only when the patient is relaxed. And the goal is to obtain reliable information without causing any discomfort to the patient. So there are fold Leopold maneuver, also known as obstetric grips, fundal grip, lateral grip, and then there are two pelvic grips. Okay, so first we'll talk about fundal grip, which is first Leopold maneuver. So you're standing on the right side of the patient. The first three grips are facing towards the mother's face, and the last grip while you are facing towards the mother's leg. Okay, so first grip is fundal grip. How to do? So you stand on the right side of the patient with the pulp of your finger. Okay, so with the pulp of your finger you place your both palms over the fundus of the patient and you palpate slowly. You don't poke it. Okay, you don't just press it hard. You just palpate with the pulp of the finger. You palpate it slowly. And what part you can encounter? So there are two parts or three parts you can encounter. First thing is you can encounter something like broad, soft and irregular mass, which may indicate the podalic end of the baby, that is the breech or the buttock part of the baby. Or you can find something smooth, hard or round mass, which may indicate head of the baby. Okay. And the third thing is you may find nothing. It can be empty, as in case of transverse lie or oblique lie. Okay. So these are the information you can get from the pelvic, from the fundal grip. So here it is being shown how you are palpating. So you palpate with the pulp of your fingers. Next, second grip is lateral grip, which is also known as Leopold's second maneuver. Similarly, you are standing on the right side and facing the mother's face. So what is the technique? Lateral grip, you palpate once on the right and then once on the left. So if you are palpating on the right side, first you stabilize the left side with your hand, one hand, and then with the other hand you palpate along the lateral side of the mother's abdomen. Similarly, gently with the pulp of your finger you try to palpate what part you can feel on that lateral half of the mother's abdomen. So similarly you can find one smooth, curved or firm structure which can be on the fetal back, or you can find something irregular knob-like structure or empty spaces which may indicate fetal limbs. And in case of transverse lie, you may either feel head or you may even feel buttock. So for junior residents who are OBGYN trainees in MD, MS or DNB institute are doing their residency, it is easier for them to make out this grips, the parts on grips, fundal grips or lateral grips or pelvic grips, but it is somehow difficult for MBBS student to make out the grips. Why? Because they are not trained, they are not doing it regularly. So it is harder for them to to understand the tone of the uterus or the skin primary patient, when the muscle tone is also good, skin is also tense and not so relaxed as in multi patient. So it is difficult for them to make okay which part is fetal head, which part is fetal back. I cannot feel soft broad structure. So it's okay. You should examiner don't expect you to tell on which grip you are finding what. You may be wrong, it's okay, that's fine, but you should know okay, how to palpate, how to do a fundal grip, what can you expect on a fundal grip. At least you should know the theory. But for junior residents, for DNB residents, you should always know how to palpate, and you should make out on your examination what part is lying there. So it's not necessary for MBBS student to find out, but you should be knowing the theory. But it's necessary for the the residents to find out what part is lying on what grips. At least you are expected. You cannot do blunder in telling about cephalic or breech presentation. Okay. Similarly, you do lateral grips on both sides. You stabilize one side with hand and then palpate the other side also. Then comes the Leopold's third maneuver, Pollock's grip. Similarly, you stand on the right side of the patient with your facing the mother's face, and then what do? With you place the the ulnar border of your right hand over the pubic symphysis. So suppose if this is the pubic symphysis, you place your ulnar border of your right hand here, and then you spread your hand like this, thumb on one side and the forefingers on one side, and then you just go and grab the part lying on the pelvis with this. So what you can get on this grip, on the third Leopold's grip, you can get either head or breech if it is not engaged. If it is engaged, you won't be able to hold it. Okay, and this grip is very deep. It is somehow difficult for the MBBS student to perform this grip, but the residents can perform it. So you can in longitudinal lie either you will get head or you get the podalic end of the baby, but in transverse lie the grip will be empty, the pole will be empty. Okay. And so I told you how to place your fingers and thumb to grasp the presenting part, and then what will you assess if there is head. So you grasp the head and you assess what is the presenting part, what is the size. If it is head, it will come between your fingers, but if it is buttock, it may not come. Okay, and if it is mobile, ballotable, which is known as ballotability. If it is ballotable, then it means it is not engaged, but if it is not, then it indicates that the part may have been engaged. Okay. So when you grab the head of the baby on the third Leopold's grip, on one side there is occiput and on the other side there is sinciput. Occiput is on the back side of the baby, and it represents the the larger mass of the head. Okay, so what does sinciput and occiput signify? So if you can feel both sinciput and occiput at the same time, then it means the head is deflexed, but if not, then the head is flexed. I know it is very difficult to determine the position of sinciput and occiput on Leopold's grip, but you should at least be knowing about the theory. No examiner expects from both MBBS and the residents to tell them about the attitude of the head, but we should know okay, we can tell the attitude of the head in this way. Okay. So the third pelvic grip is done. Now the fourth grip, which is when you face the the legs of the mother. So what do? You place the ulnar border of your both the hands along the inguinal ligament of the mother. So you come laterally from bilateral inguinal ligament and you try to go inside deep, grabbing the you try to insinuate your hand just below the presenting part. If you can converge your hand and go below the presenting part, it means that your presenting part is not engaged, but if you cannot go, it means that the presenting part is engaged. Okay, so you place your fingers of your both hand like this, you go parallel to the inguinal ligament of the mother, and then you press downward, you go down and deep, approximating your fingertips, and you palpate the part lying in the lower pole. If head is present, you assess, you confirm your third pelvic grip findings. You assess what is it, what part of your head is filled, like if you can feel the larger mass of the head on one side or not. You assess for the attitude in the same way, and then look for engagement. If you can go below the presenting part, then it is not engaged. If not, then it is engaged. Okay. Similarly, divergence and convergence, as I explained. Now auscultation. So there is some general rules for fetal heart auscultation. So in cephalic presentation, the head is below in the pelvis. So the you can hear the fetal heart sound below the umbilicus, but in case of breech, the fetal heart sound is usually heard above the umbilicus, and mostly on the side of the baby. Suppose if in cephalic presentation, on the side where the back is, on that spino-umbilical line. Spino-umbilical line is from umbilicus to anterior superior iliac spine. So this is known as spino-umbilical line. If there on lateral grip you had palpated the back of the baby on this side, then most likely you will hear the fetal heart sound on the middle point of this spino-umbilical line. Okay. So in case of occipito-anterior position, spino-umbilical line. In case of occipito-lateral, you will hear more laterally because the back will go more lateral, and in occipito-posterior position, it is more towards the flank. Okay. So the more the occiput goes posterior, the fetal heart sound will also go posterior, and in occipito-posterior position, it is very hard to hear the fetal sound because the back is direct posterior along with the occiput. So after all this examination point, you present your summary. So first you had taken the history. So what points you are presenting in summary? The positive relevant points. So Mrs. X, this year old, her OBS score, if any previous important OBS event, with low socioeconomic status, you can mention or even skip it, with LMP, EDD and POG, with her presenting complaints, and then any positive history finding. Then on examination, you tell about her BMI, vitals. If there is any abnormality on any other examination part, you tell about the obstetric examination, about the liquor part, and then if the uterus is relaxed or it is in contraction, and then lastly the fetal heart sound. So how will you know about the liquor? If you are able to palpate the fetal parts well, then it is the liquor is average, but like the fetal part is being palpable so much superficially. You can just literally feel all the parts from bone to bone. So mostly the liquor is very less. That is why it is not giving any cushion between your hands and the the fetal parts. And if you are unable to feel the fetal parts, like there should be there may be liquor maybe so much that it is making you unable to palpate the fetal parts. So that way you can assess the liquor also. So here I have just given one example of case summary. You can make your summary like this depending on the case, the history and your examination findings. So my example is Mrs. X, 28 years old. She is gravid 2, para 1, leaving 1 with previous 1 cesarean section at 36 weeks period of gestation. You can mention LMP and EDD also. Belonging to lower socio-economic class. She is a known case of gestational hypertension, currently on labetalol. If patient had told you, currently admitted for blood pressure monitoring. On general and systemic examination, no abnormality was detected. Her BP was 140/90 mmHg and pulse rate 80 beats per minute. On obstetric examination, the uterus corresponds to 36 week size, fundal height corresponds to 36 week size, lie is longitudinal, presentation is vertex, attitude is flex or deflex, head is engaged or not, and the liquor was average. There was no uterine contraction. Fetal heart sound was heard at left spino-umbilical line with a rate of 140 beats per minute. So your provisional diagnosis is 28 years old, gravida 2, para 1, living 1, previous cesarean section at 36 weeks period of gestation, with gestational hypertension, controlled on antihypertensive drugs with cephalic presentation and normal fetal heart sound, not in labor. So in last always mention not in labor in case of term patient, okay, if patient is not in labor. So thank you guys for listening to my video. You can ask me if you have any doubt or you haven't understood any point in the comment section. So thank you for listening to the video. Please subscribe and like the videos for further videos, and you can watch my previous one on obstetric history taking. Thank you.